All right. Hi, everyone. Thank you for joining in to today's shadowing session. Today, we're joined by Dr. Murphrey. Dr. Murphrey is a resident physician training in dermatology, currently a PGY3, I believe. Has had experience in not only dermatology, but also healthcare ethics and across the board with research, mentorship, leadership, really anything in terms of mentorship, experience, you name it, Dr. Murphrey can help you out. So we're really excited to have Dr. Murphrey today with us. Just as a few reminders, as general for our shadowing sessions here. For those listening, we're going to have a quick Q&A at the end with any remaining time we have after Dr. Murphrey's presentation. We're going to be going through just in general dermatology, and we'll have the opportunity to ask Dr. Murphrey questions. So in the chat that you see at the bottom of this live stream, you can type any questions that you have for Dr. Murphrey, and we'll get those answered for you. And for those who are interested in more shadowing sessions, we have plenty more coming up in January, February, March, and April. We're currently scheduling more in May, but we have ones throughout the spring semester. This is our first one, actually, to kick off the spring 2022 semester, so we're really excited for it. But if you're interested in joining more, what you can do is you can go at the bottom of our website's homepage. At the very bottom of it, you'll see our Google Calendar, and there you can register, not register, but you can view sessions and just look at the days and times for each of them. We record them on Thursdays starting at 7 p.m. Central. We have the live stream just like you see here for all of them, and they're available from then on our YouTube page. And we have the quiz at the end of today's session. So if you're interested in getting credit for this session, we have our quiz, and just fill that quiz out. If you get 6 out of 10 or 60% on your first attempt or more, then you get credit for that. But with all that out of the way, I just want to give the floor to Dr. Murphrey. Go ahead and take it away, Dr. Murphrey.
Okay, well, thank you so much for that introduction. I am Morgan. I am a PGY3 dermatology resident at UC Davis, and I'm going to talk a little bit today about how I got there and what it's like being a dermatology resident, what dermatology is all about, and why you should consider this awesome field. So if you have questions, please do put them in your chat option, and I will address anything at the end. Okay, so this is kind of my path. I went to undergrad at Cal Poly, California Polytechnic State University in San Luis Obispo, California. I was a biochemistry major and I was a psychology minor. I actually started as a psychology major, but I ended up switching over to biochemistry because I couldn't get any of my classes because I was in an impacted at an impacted university. So that's why I ended up being biochemistry. I just mentioned that because you don't have to be a science major to go to med school. You just have to have the prerequisites done. And so if you wanted to major in something else, it's totally okay. I went to med school at Creighton University. And Creighton is really interesting because the first 2 years are in Omaha, Nebraska. And then the second 2 years are either in Omaha, Nebraska or in Phoenix. And so they have a sister hospital over in Phoenix. And so I was actually able to do my third and fourth year of med school in Phoenix. So I was in Omaha for first and second year, then Phoenix for third year. I ended up taking a year off from medical school to do a research year. And just keep in mind, I did go straight from undergrad to med school. So that kind of factored into my decision too. This was sort of my first sort of break from school. So that's part of why I took a research year in between my third and fourth years of med school. I was at Northwestern for that. I also ended up completing a master's degree in healthcare ethics at that time. And then I finished up med school and now I am in residency at UC Davis. I'm in Sacramento, California. And just one small addition here, for certain specialties like dermatology, anesthesiology, radiology, ophthalmology, after you finish med school, you don't just go straight away and start your residency training in those fields. you actually take a year and you do a year of internal medicine or surgery or peds. You can apply to any of these three options. So I did a year of internal medicine in San Francisco. So that was my PGY 1 year. And then the last year and a half, I've been doing just dermatology. So that's kind of everything I just mentioned. I think you guys are mostly in college. And so just to give you a sense of some of the extracurricular activities I did and sort of what my application looked like when I applied into medical school, I was pretty involved in my sorority, Sigma Kappa sorority, and I was the vice president of philanthropic events. I did that for 2 years. And then I also worked. I had a job as a surgical assistant for a periodontist. I did that for 3 years. I did quite a few humanitarian trips to Nicaragua and actually started that when I was in high school. So it's something that I continued on through undergrad. And then I went where I was at for undergrad, there were two hospitals. And one of the hospitals, it was like I couldn't get any job there, like any shadowing job. Like the volunteers were already full, the scribes were already full, they didn't have anything. So I actually went over to the other hospital in town, which was a smaller hospital, didn't have as much student involvement. And I started their emergency medicine student volunteering program there. So I did that as well. And then I worked on research. I worked on an inorganic chemistry project working on creating a ligand that binds reactive oxygen species. And when it binds, it fluoresces. So we basically manufactured the ligand and then did some studies to show that it bound. Okay, so to give you an idea of medical school, so my first 2 years and everyone's basically first 2 years of medical school are primarily coursework. So you have your sort of general courses like anatomy, physiology, biochemistry, and then you have your systems-based courses where you kind of take a body system like the heart or the lungs or the kidneys, and you study it very in depth and the physiology and the drugs and take a holistic look at every specific organ system. At the end of your second year of medical school, you take an exam called your step 1 exam to sort of prove that you've learned enough the last 2 years. And then you are able to start your clinical rotations. And that starts your third year. I did those rotations in Phoenix, as I mentioned earlier. And so you rotate through various portions of the hospital. So in internal medicine and surgery and psychiatry and peds, most rotations are 8 weeks. At least that's how they were at my program. I think some places are 6, some places are 10. So you spend a decent amount of time working in these various departments of the hospital. And then at the end of it, you take a shelf examination, which is a test on whichever system or whichever part of the hospital and the department you've just been working with. And then I just mentioned this role of a medical student. As you progress through medical school, you'll find that your role changes. When you're just starting, you're really just expected to kind of report information and be able to like find key labs and then report them back to the team. As you progress, your role changes and you become more of an interpreter. So not just here are the labs, but here are the labs and here's what that means. And then eventually you become more like the manager, where you can identify and report the information, you can interpret and understand what it means, and then you can actually manage it and come up with a plan and sort of resolve the issue. And then finally, last step, educator, where you have sort of achieved all of those things and now you're teaching others how to do that. And that's kind of how medicine and the process of learning medicine and understanding how our systems work and how our teams work. That's kind of the progression that you will make as you complete medical school and then go out and are a physician. Okay. I did that research fellowship that I mentioned in Chicago. And part of that was because it was good timing for me where I was in my life. And part of it was because I wanted to make more connections within dermatology, my desired specialty, and also work on some research papers, things like that, kind of supplement my resume a little bit. So that was a great year. And then I spent my your fourth year of medical school. The bulk of it is really applying for and interviewing at residency programs. So I did that. And then I finished up some coursework, did a little traveling. This was pre-COVID. So enjoyed that while I could. And then I started residency. So why derm? Well, it's a very visual field. And that's just something that really attracted me to it. It's stuff you can see for the most part, which is pretty cool because your physical exam, like you go in, you look at the patient, and you have a good clue of either what's going on or what test you need to figure out what's going on. And so that's something I love about this specialty. It's a great mix of both complex and more routine conditions. So we deal with complex autoimmune blistering diseases and medications like immunomodulating medications or biologics. I mean, we get into that stuff, but we also see acne, and we see, run-of-the-mill eczema, and much less acute, but still chronic conditions. And so it's sort of fun because you have a nice mix of both complex and sort of routine visits throughout the day. We do lots of procedures. We really rely on being able to do procedures and harness those techniques and skills. And we use biopsies for much of our diagnostic workup. We see patients that are everywhere from babies to 100-year-olds. I have seen 100-year-olds, 102-year-olds, which is so fun. And we are in the outpatient setting. I didn't feel a strong need to be in the hospital. And this was something I really liked. I like that I get up and go to a clinic, and it feels a little bit more like work, like a job like that to me. Other people really prefer the hospital. Within dermatology, there's lots of options. You can kind of take different career paths. And it's an area of very active research. There's tons of new developments. And so if you are interested in a cutting edge field, this is it. We talked about this a bit already, but it does require an internship prior to actually starting training. So I did that at California Pacific Medical Center in San Francisco. And then now I am at UC Davis in Sacramento doing my dermatology residency. So scope of practice, dermatologists see general and medical dermatology, surgical dermatology. We remove skin cancers with excisions. We also do Mohs surgery. It's a tissue sparing surgery. It does require a fellowship. We look at the pathology. So we look at the skin cells right then and there as we're doing the procedure to make sure we get it all. We do laser medicine. We see pediatric dermatology in kids, immunodermatology, complex medical derm paths. That's a big part of our specialty. And actually, you can be a dermatopathologist, meaning your primary role is to look at microscope slides, look at slides into the microscope, and evaluate the cells and use those samples and images to help the dermatologist make the decision. And we also do cosmetic dermatology as well. So Pearls of Dermatology, it is a 3-year residency. You can pursue a fellowship at the end. Most are 1, very few are 2 years. All different practice settings. There's academic, there's private practice. There is a lot of research involved. And if you're interested, you can go into the academic setting. It's primarily outpatient, although we do see inpatient hospital consults, but you really would only do that if you're in the academic setting. And our schedule, it's Monday through Fridays, kind of 8 a.m. to 5 p.m. job. We don't really do call, although in inpatient dermatology or call or consults, like in academic settings, you would have times where you are on call. We see so many conditions: eczema, acne, psoriasis, all different types of rashes. And I think something people don't always think about with dermatology is we see all the cutaneous neoplasms. So all the skin cancers, whether it's basal cell or squamous cell or skin cancers like melanoma, we see those patients, we sample those patients, we treat those patients, we help with their chemotherapy. So we are doing a lot of actually sort of oncology as dermatologists and tons of procedures. We do skin biopsies, we do steroid injections, we do cyst removals, comedone extractions, we do chemical peels, excisions, Botox fillers, laser hair reduction, laser hair removal, laser resurfacing. We do hair transplants. We really do it all. Okay, so yes, this is kind of how the days go, clinic, and then as a resident, you're studying, we take exams still as residents. Okay, so I wanted to just shadow a couple of cases. It's early yet, and then there will be time for questions. So let's go through. So we talked about this rhyme model. Okay, so we have this first case. This is a patient who's coming in. This spot has been present for 5 months. It's growing, it's tender, and sometimes it bleeds. So what would you think about for this spot and how would you treat it? So looking at this spot, it's come on over the last few years. It's tender, it's growing. These are all things that signify to us this could be potentially a skin cancer. And so what we would want to do here is take a biopsy or a sample, and this is a pretty much bread and butter procedure. I did 3 biopsies today. We do biopsies all day, every day. So I'm going to show you here the biopsy. So this is a shave biopsy. This tool I have is called a dermablade. And you see that you can just use it and literally like a little tiny razor to shave the skin and shave the sample off. And then you take the sample and you put it into a specimen bottle, and then the pathologist process it and look at it under the microscope. On the right here, you're going to see me doing a punch biopsy. So this is the punch biopsy tool. I sometimes compare it to like a cookie cutter shape. So we go ahead, we take the tool, we go all the way into the skin there, we remove the sample. And then with these guys, we actually then go in, we look at the skin, we see where does it stretch, where are the skin tension lines, and then we actually put a stitch. And so we can do this in our clinics. We can do this at the hospital bedside. I was just doing biopsies at the hospital today. If inpatient teams need our help. So this is exactly what you do here. And that is it. That is biopsy. Okay. So what is the treatment for this? So we would, if we test it and it is in fact a skin cancer, probably is, then what we would do is a surgical excision. So you take the skin cancer, you draw margins around it. You put it into a shape that can be sewn back together, which usually is one that looks a little bit like a football. And then you remove all that, you send it to the pathology lab, you sew them up, and that's surgical excision. Mohs is where you remove just only where you can actually see that there's a problem with the skin. And then you actually look at it right then and there under the microscope while the patient waits with gauze on their face or their wherever where the procedure is being done. And then you look at it under the microscope, see if you've gotten all the skin cancer. If you have, then you sew it up. If you haven't, then you go back and you get the rest of the skin cancer and you keep doing it until all the skin cancer is cleared. So Mohs is a special type of skin cancer surgery. The reason we do it is partly because the clearance rate is so high, it's at 99%, partly because it's what we call a tissue sparing surgery, where we actually are looking at the skin under the microscope. So we don't have to just take a big margin like we would with the surgical excision. We actually just take a teeny little margin. And so in that way, we can end up not making as big of a hole or defect where we have to remove skin. And so in that situation, the smaller the hole, the smaller the scar, the smaller the closure. Okay, case 2. So we have this patient here. You can see they have a rash. It started over the last 48 to 72 hours. And you're taking a thorough history and you learn that this patient was recently treated for a urinary tract infection with Bactrim, trimethoprim, sulfamethoxazole, a type of antibiotic. So what is the next step and what is the treatment plan? Okay. So in this patient, what you would do, you're suspecting that this is likely a rash that's been caused by a drug, Bactrim. And so you want to stop the Bactrim, stop the offending agent when you're worried about a drug-related rash. You can treat the symptoms topically, typically. So we use creams like triamcinolone. It's a steroid to the entire body, and we use it as a topical cream to try to treat the rash and the symptoms. Now, if the patient is having a severe rash or there are systemic symptoms, we may need to take a bigger treatment modality with oral steroids. And then you need to talk to the patient about how this goes because their skin is probably going to slough. They're going to get scaly. It's going to kind of regenerate. Most of the skin, part of the reason you're seeing the rash is because of changes in the blood and the vasculature. And it can often cause some of the skin to sort of die and then shed and slough off. Okay, here's our third case. This is a patient who's had the skin findings developing over the last few months. No one in the family has any similar rashes, and this is just somewhat itchy. So what are you thinking about here? Well, here we are thinking, what would we think about and what is our next step? So with this rash, you can see that it's very well demarcated. It's got these very easy to detect borders. And on the rash, it's quite red, but it has this sort of snowy, silvery white scale. And these are all sort of high yield clues that you're looking at psoriasis, and this location as well on the extensor elbow surface here. So if we did a biopsy, this is what I've kind of been talking about, where you do a biopsy and then you go ahead and you look at it under the microscope. And this is actually what the skin looks like under the microscope. So, up here we see this is the stratum corneum. And then this is the epidermis here. And then this is the dermis. And this is the papillary dermis, where it's coming up in between what we call these reedy ridges of the epidermis. So, and like if you get a blister kind of thing, it's usually somewhere around here is where it separates and fills with fluid. And so it's like this junction is kind of the connector between like the skin that you can touch and like what you see under a blister. So this is that. And in this particular sample that we've taken, we see parakeratosis. So these cells up here have nuclei, which they shouldn't. We see epidermal neutrophils. So within this epidermis layer, there are neutrophils, which typically is not a cell we see here. We see that the reedy ridges here are elongated. It kind of looks like a rack of test tubes. And we see dilated blood vessels here in this papillary dermis. And these are all the things that mean psoriasis when we look at it under the microscope. So what do we think for treatment? Well, there's lots of new treatment options for psoriasis. We can usually, if it's a small surface area, treat it with just topical steroids or topical steroids plus vitamin D cream. Calcipotriene is the name. But if it's a larger surface area or if it's refractory and it's not responding to topical steroids, then you can think about a biologic, which is typically an injectable medication, although there are a few pills. And these are more targeted therapies that, based on our studies of the immune system and what we've learned about the pathways and the biochemistry and the pathophysiology of these skin diseases, we found ways to actually target specific cellular pathways. And you guys are probably way up on this stuff right now because you're probably taking like biochemistry and courses like that. So we're dealing with interleukins, and they're targeted medications that actually either target receptors of interleukins and other chemokines, or actually go in and basically kind of they can competitively inhibit, or they can actually target the interleukin itself. So kind of preventing it from binding to the receptor by, changing its configuration by binding to it. So it's really interesting. And if you like that kind of stuff and, you enjoy that kind of scientific, if it's interesting to you, derm is great because we do so much immuno and immunology and immunobiology. Okay, so that's all I have for you. And now I'd be happy to take any questions. I've provided my information here, my email, my Instagram handle. I haven't been as active on it. I'm trying, but just, try to show what it's like being a derm resident, and help anyone and answer any questions. I have a website as well, morganmurphreymd.com, which has a lot of my publications and experiences and research and my contact information as well. So I'm happy to help and here to help if anybody would like to reach out. And if there's any questions, I'd be happy to take them now.
Yeah, that sounds great. Thank you so much, Dr. Murphrey, first of all, for that amazing presentation. I'm sure that going through the patient cases, going through in general what dermatology is, your own experience in training with it, that was very, very interesting to hear. And it really gave a good overview of the field. We have our first question here. A student asking about, during medical school, do you focus on just strictly clinical rotations for experience at one point, or do you work outside of school as well? As in, I think that they're referring to a job or unpaid internship, something of that nature during medical school.
Yeah. So medical school, I would say 99% of medical students do not have any outside jobs. It's not quite the same as undergrad or like college where you're able to have a job and go to school. Medical school is unfortunately like a pretty full-time job. You have class Monday through Friday from 8 to 5, and then there's exams that you have to take. So when you're doing clinical rotations, it's more starting in your third and fourth year, and your first and second year are all about mastering the knowledge. My school did have something called a continuity clinic. Or I think that's what it was called. I'm pretty sure it's called continuity clinic. But anyways, it was a clinic that I would go to and shadow at each week, or every single week. So one day or one half day a week, I was assigned to this internal medicine clinic, this one specific doctor, and I would just go to his clinic and shadow his patients with him. It was an outpatient clinic. It wasn't like a hospital rotation setting. So that was the sort of shadowing, rotating clinical experience that I had my first 2 years of med school, was that weekly half day. And then once you get to your third and fourth year, all you do is be in the hospital. So I think that was something that surprised me about medical school, was like, oh, your first 2 years are just a lot like college. Like you're just still just learning stuff. You're just learning like a lot more than you ever had to learn in college.
Definitely. We also have another question, really asking about the bread and butter of dermatology. You covered a few cases there in specific patients, but whenever you do get called in, what are the common cases that you usually see? And are there any emergencies that you deal with in dermatology?
Yeah. So basically, dermatology, as I was mentioning, it's a primarily outpatient based practice. And so I get to my clinic at like 8 a.m. and then I have patients scheduled, all day long. And the visits are 15 minutes. So my patient visits, our bread and butter conditions are, let's see, I think I put this. Yep. Here. So we see eczema, acne, psoriasis. We see all kinds of rashes. A lot of new patient visits will be, I have this itchy rash. And so I like to think that we are basically detectives, because it's almost like when you take your car to the mechanic and you don't really know what's going on, and it's like the mechanic has this black box of understanding that you just don't have. And that's kind of how we as dermatology are with the skin, because so much of the skin is like very nuanced and kind of esoteric. And so as dermatologists, we know about all of the random one-off diagnoses that are more rare, but that's sort of why we're here, because we know about all those, we study, we understand, we know what they look like clinically, and so we can kind of offer that expertise. So somebody might just seem to be coming in for something run of the mill, and then because we know the questions to ask and we know the clinical signs to look for, we end up spotting that they have dermatomyositis and they have this autoimmune disease, and we need them to get a lab workup and work with the rheumatologist. So that's kind of a cool part of our job, and something where you might think somebody's coming in for something boring and it's actually really interesting. And then skin cancer is another huge thing. And then, in terms of the hospital stuff we see a lot of rule out Stevens-Johnson syndrome, which is the true dermatologic emergency. It is caused by it can be caused by various things, but basically what you see is that patients have skin blistering and sloughing, and they essentially become like burn victims because they lose large amounts of skin. And so once you get to a certain, like over approximately 1/4 of your skin being involved, this is when you get into the emergency category, because it causes lots of hemodynamic shifts if you don't have your sort of skin to keep everything in, lots of water loss, that kind of thing. So that's a big derma emergency we get called into the hospital for. And then we get called into the hospital for a lot of chemotherapy rashes, onco patients, stem cell transplant patients. Today I got called, let's see, I'm on consults right now. In the last week, I've seen a patient with acute graft versus host disease. I've seen a patient with scabies. I've seen a patient with edema bullae because they were cupping their legs. It was really interesting. Today I saw a patient who has cutaneous T-cell lymphoma with these like huge nodules that we biopsied. So we see all kinds of really interesting stuff in the hospital for sure.
Definitely. We have another great question from a student asking, did you always want to become a dermatologist, or were there other specialties / avenues that you were also interested in?
Okay, that's a great question, because no, I definitely didn't. I actually didn't even know I wanted to be in medicine at all when I started undergrad. I thought I wanted to be a psychiatrist. And so, I thought I wanted to be a psychologist. And that's why I got that psychology minor. I actually started as a psychology major. And I really wanted to be like a licensed marriage and family therapist. And then I realized that if I was going to go down that road, I would want to potentially be able to prescribe. And I got interested in the kind of dialogue of like prescriptions and mental health and all of that kind of stuff. And so that led me to want to be a psychiatrist, which does require you to go to med school. I don't have anybody in my family that's in medicine, so I had really no idea what I was signing up for. So you guys are real smart to be taking this little talk or whatever this we want to call this, because it's it's a whole process that if you're not familiar with, you can get pretty caught off guard. And so that was my experience. And then once I got to medical school, I shadowed some psychiatrists, realized maybe psychiatry wasn't for me, and then kind of stumbled my way into dermatology after thinking about psychiatry, thinking about OBGYN, and thinking about, I was actually interested in emergency medicine for a short period of time. I think the main things when you're thinking about your specialty are, do you want to be in the hospital setting or the outpatient clinic setting? And do you want to be surgical, procedural, or do you not? Because once you kind of decide how you feel about those things, each specialty, there's not really there's some specialties that are all of it, but most specialties kind of kind of go into one of the quadrants. You're either more inpatient or you're more doing procedures, and some specialties you're more outpatient and less doing procedures. And so based on what you like doing, that will help you refine your specialty choice.
Absolutely. We also have another student asking, she knows a lot of medical schools that, or medical school books that don't necessarily talk about the images of ethnic skin. Did you find it hard to recognize in maybe the early days of your training certain cutaneous diseases on people of color?
Well, it's actually interesting you say that, because I am part of the diversity inclusion and a task force within our department. And we had a very amazing research fellow who was working with us. Her name's Alexis Carrington. She has an Instagram if you're interested to see what she's up to, but she's pretty awesome. Anyhow, all that to say, we were part of a multi-site project where we created an atlas in dermatology for conditions in skin of color. And Alexis really spearheaded it at UC Davis. And so it was actually just released, I think about maybe 6 months ago, and it was provided as a free resource to all dermatology residents, including myself. So that book is fantastic. It shows every most skin conditions in all skin types, phototypes. And so it's really a valuable resource. And while I think it's true that it's been a big fault of education, I think people are becoming highly and acutely aware of the fault that's been made within, not having that in textbooks and things like that, and are working very hard to try to correct it. And so since I've been a resident, it's really been kind of, I've seen the shifting happening. And I think by the time, if you're interested in dermatology and by the time you might be a resident, I think actually skin of color will be much better represented in textbooks and in education. In terms of my actual training, I'm in one of the most heterogeneous cities in California and see patients of every skin type, and have fantastic faculty and skin of color clinics. So I get a lot of training and experience. So it's cool. It's really cool to see the shift happening and to learn.
Absolutely, definitely. There's another question we have specifically over the research. You yourself have been involved with a master's degree before medical school, and also have been continuing that research pursuit, your research pursuits through residency. So you have quite a bit of experience, and they were just wondering, with dermatology residencies in specific, is it more of, there's some niches that some residencies might have towards having more publications versus others who might not require as many. But they're just wondering in general, is it important to have a publication, or would research and publishing on topics and other specialties be weighed equally? So really, what's the distribution? Does it vary from one specialty to another when you're applying to residency, or do each of them have more weight on that factor of the application?
Well, I hope I answer this question correctly, or I hope I answer it to whomever's asking. So if you have a follow-up question, feel free. But I think what you're getting at is, do you need research in dermatology to apply into dermatology? And the answer to that question is, I would recommend it, but you don't have to have it. Within dermatology, it's a competitive specialty, and most people do have multiple derm-related publications. There are, of course, people who are exceptions to that rule. But I think in general, it's worthwhile to have something related to dermatology that you've presented or published on your application. This is talking about when you're applying for residency. If you're just applying for medical school, you can have whatever research experience you might have on there. It's sort of irrelevant if it's related to dermatology or not. But when you're going into residency and residency application, I think it's worthwhile to have something related to derm that you've published.
Absolutely. And maybe going off of this topic, a good segue would be to just discuss the research process in general, the publication process in general. Sometimes people are new to the idea of peer review, to the idea of impact factor, et cetera, all of which are important to know when diving into research, because it's just with the world of academia that is valued. So could you give us maybe a quick overview of what those are? What is peer review? What are impact factors, and what is important outside of just publishing in research?
Yeah, no, of course. So, the Wild West of research. Okay, so basically, research is related to publications, but they're not the same thing. So research is whatever project you happen to be working on where you have a question, you design a study, and you seek to answer that question, right? Okay, so that's research. Now, when you do research, you often have results, and those results can then be written down in a scientific way where you go through and document what you did and how it worked and what you found and the conclusions you've drawn from that. And then you can submit that to a journal to basically share your research, because there are journals that take people's research and publish it so that other people can see what's happening, who's working on what are they learning, and they can use that information to better inform either their practices or their own research questions. So this is kind of the general framework. You do research, you come up with results, you write it up, and you publish it in theory, a journal. Within the publications and journals world, there is a bit of a hierarchy, which is merited, because if you just can publish anything and say anything, who's to say that what's out there is even right? Like, somebody should probably be fact checking this stuff before it just gets distributed to the whole world, because it could be wrong. And that's kind of where peer review and impact factor comes in. Peer review is the process by which you submit your paper, your research, your findings, your results, your conclusions, you write it up, you do citations of other people's work included within it, and then you submit it to a journal. And then peers, so people who have been selected by the journal, who are in theory advanced or expert in their fields, go through and they edit and read, and they review the article, and then they provide feedback to the author and to the editors. And they either say, they've made some critical errors and we don't think this should be published, or, they've made a few errors and we think they can be fixed and it might be worth publishing after we take another look, or, wow, this is life-changing and it should be published. And so that's the idea of peer review, is that there's sort of somebody who's going back through. Now, it would then make sense that journals that have great reviewers who are experts, who diligently review articles and, all these types of things, that they then produce journal publications data that's really reputable, it's clean, it's reproducible, and it is valuable. And so that part of that plays in, and how long the journal's been around, how many publications the journal's putting out, how many people are reading the journal. All of those things go into one single score called impact factor. And journals that are of a higher impact factor are generally more respected and generally harder to have your work published in, because the review process is scrupulous and things being reviewed are not necessarily going to be accepted, or, so only the best of the best will actually get into the article. I mean, sorry, into the journal, where in a journal with maybe a lower impact factor or less of that, any old article can get in there, and you have to be a wise consumer as you're looking at research, because this is barely peer reviewed and it's out there, but it could be wrong. So that's my long-winded answer.
Definitely, I mean, it definitely explains it really well, in terms of like for someone who doesn't have really much experience with the whole idea of publication, and research in general. For those, thank you so much for that rundown of it. Going back to dermatology in specific, you mentioned that it's mainly held in an outpatient setting, and also with that said, also I think maybe that ties into how it's held also mainly in, or at least to some majority, in private practice. Is there any rhyme or reason behind why that is, or is it just how things have developed over time?
Well, it's because everything that needs to be done can be done in an outpatient setting, right? So there's going to be some specialties where you're dealing with problems and diseases that don't allow for the patient to just go home in between treatments or go home and do their treatments at home, right? They have problems that need to be addressed in the hospital. Whereas specialties that are outpatient, or visits that are outpatient, are such because the issues don't require the person to be hospitalized, right? The person can just come in, we can take a look, we can talk about it. If we need to do a small procedure, we can do an in-office procedure, and then they can go home, and all of their treatment plan, whether it's the creams they're applying or the pills they're taking or whatever, all of that can be done at home, and then they'll just follow up in the clinic. So I guess the rhyme and reason is how acute the problem is, and can the solution happen at home, or does it have to happen in the hospital?
Yeah, that's definitely insightful. I myself, I was wondering about it personally as to why, and definitely thinking about it now, it makes a lot of sense. And in terms of the treatments you mentioned, one of them was biologics. There were an array of others that you mentioned, but what are the common side effects that come along with these kinds of treatments?
The common side effects?
Yeah, are there any minor or major ones, or is it mainly minor?
So most of the side effects are related to the actual medication. If we're talking about like biologics in general, these are biologic is kind of a catch-all term, and typically refers to a an engineered medication that is an immunomodulator. So it interacts with your own immune system in a variety of different ways. And so with these, sometimes we see slightly increased risk for tuberculosis. And so we always have to check for tuberculosis in pretty much every single biologic. And then sometimes we can see increased risk of infections because these are immunomodulating. And then sometimes we can see like skin cutaneous findings, like, for example, increased risk of candida or tinea in the skin. So those are just the most sort of general side effects that we see for immunomodulatory medications we're terming biologics. But in general, lots of different medications have lots of different side effects, and it's really kind of like a medication by medication basis. Like one thing might be in the same class, but causes a totally different side effect profile, because all medicines are sort of unique.
Definitely. You mentioned a few of the fellowship options. One in particular that I caught on was Mohs surgery, and I'm sure there are many more. Could you take us through the details in terms of what those individual fellowship options go through in terms of training, and how many years they usually are?
Yeah.
Dermatology?
Yeah. So most of the fellowships are 1 year. Fellowship options. So you don't have to do a fellowship. You can just graduate dermatology residency and be a dermatologist. You can do a fellowship. Various fellowships that you can do include pediatric dermatology, where you spend an additional year focusing on just kids. And typically those people then go on to only see kids in their practice. There is laser and cosmetic surgery fellowship. There is Mohs surgery fellowship. There is dermatopathology fellowship. So that skin slide, the people that are taking the biopsy and looking at it like this under the microscope, that's dermpath, and those are the dermatopathologists. And that I think is all of them. I feel like I might be blanking on one. UCSF has like a medical dermatology fellowship where you can go and spend the year working on a consult team and seeing inpatient hospital derm. I think these are the main ones. Yeah. There's a cutaneous oncology fellowship at Harvard, I believe. And it's like all about skin cancers, and cutaneous malignancies.
I see. And for just patients in general, is it more common that you'll see a rash with these patients of some sort, or do some patients come in without a rash in those bread and butter cases, but still see the dermatology department for something like, for example, itchy skin without necessarily a rash?
Yeah, I would say rash is about 50% of what I see, maybe less, maybe 40%, depending on the day. But we see like keloids, scars, acne, we see skin cancers, we see other things that are more like discrete papules versus all over rashes. So we see some rashes, but we see a lot more than just rashes.
Absolutely. In your research experience, you've gone through not only publications, but also conferences. Could you take us through the importance of conferences in the grand scheme of research? Are they more valued than publications? And what about abstracts, which are not necessarily publications, but have kind of a different place in the whole scheme of things?
Yeah. So basically, if you're going to go to the conference just to go, that doesn't really make any difference in terms of your application or your CV that you've attended a conference. That's more for you, so you can either network or learn or whatever you're going for. What would be more valuable from a conference, or I guess what would be actually valuable would be if you were to present a poster at the conference, or if you were to give an oral presentation at the conference. Typically, the way you do this is the conference will let people know, okay, abstract submission, oral poster presentation submission, it's all available, it's all open. And then you submit your abstract, and then at least with like the American Academy of Dermatology, it's either accepted to be sort of less, it's either accepted to be a poster or it's accepted to be an oral presentation, with an oral presentation being slightly more prestigious. And so if you have, and then typically what will happen is that in the conference journal, the poster or the oral presentation that you've given will be represented as an abstract, which is considered a publication. And so this is kind of the schematic, right? Like the poster or the presentation are things you actually do at the conference. And then the abstract is usually what comes from it, where you've had something like published out of it. You can put them all on, if you do a poster and it's published as an abstract, you can put both on your CV. And in terms of what's the most important, the very most, I think, important thing is either book chapters or PubMed indexed articles that you have published. And then after that would be oral presentations, poster presentations, and published abstracts.
And across the board with publications, there's different categories. Some of these journals, I think, are even dedicated to them. So, for example, like BMJ case reports, that's dedicated to specifically case reports. And there are a few others that might not necessarily like have a certain publication type that they promote or restrict to. But in your experience with these different types of publications, from like, let's say a literature review to clinical trials even, what is the time range that's taken for each? I would expect that clinical trials will be more, but like in terms of set number of months or years, what's the expected time commitment with these going into them?
Well, a short letter to the editor, you can maybe do in a couple of months. And then something like a clinical trial that you're writing up could take years. I mean, it depends how long the trial's running for. That's part of it's how you design the trial. A review you could write up in 2 weeks if you just worked on nothing but that, and submit, because it's not dependent on, you're just reviewing what's already out there. So it's just you sitting at your computer getting the work done, so the timing is very variable, is the answer to your question. It really depends on what you're doing. I'll just say this, everything takes longer than you would expect. It's always a truth where research, it just takes a long time, because if you have to file an IRB proposal, and then the IRB only meets the third Wednesday of the month, and it's just, everything takes more time than you expect that it would. And people are sensitive to and aware of that.
Absolutely. And we'll have two last questions that we have in the chat to wrap up today's shadowing session. We hope that everyone listening has enjoyed. So the first of those two questions is a student asking, first of all, saying that there's a lot of new treatments that have been promoted, and they know someone with hair loss that is trying a variety of these treatments, and many of those new drugs are hitting the market. So how do you stay up to date to ensure that you're being offered, or at least taking, the best of those treatments?
How does the doctor stay up to date, or the patient?
I think that they're referring to the patient in specific. What resources should they use, especially with the rate of new treatments that are being promoted? It's kind of hard to digest all of this information. And going back to the doctor each time might not be like the optimal case for patients who are trying to, see what they can do and are hearing about these new treatments very frequently.
I would recommend visiting the American Academy of Dermatology webpage. There's tons of patient resources there, and they're directly from the American Academy of Dermatology. I'm on the Residents and Fellows Committee of the AAD, and it's a really fantastic organization. And there's a lot of effort put into supporting the public and educating the public. And so I think that's a great jumping point. But in general, it's really your dermatologist's job to stay up to date on the literature, to stay up to date on treatments that exist, to stay up to date on new things that are coming out. And so ideally, if you are, if you trust your dermatologist and you believe in their ability to, digest and manage new treatment modalities, you should be able to get a lot of that information directly from your dermatologist.
Yeah, I think I might have interpreted that wrong. They actually just mentioned in the chat that they were referring to the doctor in specific. So I know that you mentioned a few points specifically about the doctor, the dermatologist's side of things. Anything else that you would like to add to that in terms of how does the doctor keep up with the most optimal treatments for patients?
We read journals. So we read the Journal of the American Academy of Dermatology, the JAD and the JAMA the Journal of the American Medical Association for Dermatology. Those are our two main highest impact factor dermatology journals, which my program, we meet every single month and review the articles from. So that's really how I stick with it. And then I receive an email blast called Derm Daily, which summarizes the most important research articles that have come out that day within dermatology. Usually it's about 6 articles and it gives me short summaries of them. So I read that pretty much every day. So that's how I do it. It seems like there's a million new things, and there sort of are, but it gets easier to digest it all when you start to when you understand it a little bit better.
Definitely. And our last question, I think, just to wrap up today's session. Again, thank you so much for answering all these questions and giving us that great presentation over dermatology. I think so far we've received so much great insight over it. So our student is asking here, we're presenting at a conference in high school, particularly the summer before starting college, so almost just right next to starting with undergrad. Would that be counted towards your med school application? Do med schools consider that? And is it something that would be a smart move to do, even though it's just before college?
Yes, anything that you've done, you can put on your AMCAS application. So if it's still AMCAS, which is what I think, if I'm trying to remember, I'm pretty sure I used AMCAS to apply to med school, right? I've used so many now. I've used ERAS since then. I've used VSAS since then. So I can't remember which one's which, but anyway, that application, you put all your experiences since forever on there. So, I mean, you put the date, they'll know that it was before you started college, but if it was an interesting thing that you presented at a conference, I mean, even if it was a few years before, like an interesting thing's an interesting thing. So I would say don't rest on your laurels just because you have that conference. That's a great experience. Don't think that now you're in necessarily, you know what I mean? Like keep going with that great momentum and don't let yourself be complacent, because any other experience will just continue to enrich your application in your life.
Absolutely. I think one last thing maybe we can cover quick. I think this brought up a great point about applications, and you mentioned it there. As you progress through your career, things, or at least maybe the admissions committees, the people viewing your applications might consider them to be less relevant because it's been a few years back. So for example, I've heard of the common phrase, if you go one step forward, they look 2 steps behind. So with residency, they'll look 2 steps back. With medical school and your undergrad years, for medical school, they'll look at high school and college. Have you found that to be true with your experience going through applications for medical school, applications for residency? Is that generally a true statement, or what are your thoughts on that?
To be frank, I don't think I understand this statement. Well, I don't know. My experience has always been that everything on my application was relevant and reviewed, even if it was a long time ago or more recently. And for example, I sit on the admissions committee for UC Davis Medical School and read applications and do screenings for that. And I mean, I look at when somebody did something, but I look at their whole application. So I think if you had a paper accepted to a journal the day before, that's great, and you'll see it, or a year ago, that's still great. It's just put everything on there.
Okay, yeah, definitely something to keep in mind, especially heading into application season. So I think that really wraps up today's session. Thank you so much again, Dr. Murphrey, for coming in, taking some time to join us. We've learned so much, and I'm sure there are a few people out there who've maybe picked up an interest in dermatology after this session. So it's always great to have this exposure. For those listening, for our shadowers, we just posted the quiz in the chat, so you can take the quiz. Again, 6 out of 10 or higher to pass the quiz, and you'll receive a certificate with the email that you put in for the quiz. Also, we have our quiz available on our virtual shadowing page on the site. The quiz will be due 11:59 Central Standard Time this upcoming Wednesday, January 19th. And we're going to have our next virtual shadowing session the next Thursday, January 20th at 7 p.m. Central with Dr. Olasanya. That one will be over physical medicine rehabilitation. Again, thank you so much, Dr. Murphrey. If you want to hear, by the way, if you want to hear more from Dr. Murphrey, we only have 1 hour to try to cover things. So I'm definitely sure that a lot of us would like to hear from the doctors we have. So you can follow her on her Instagram at Morgan Murphrey MD to hear more from her. And once again, thank you so much, Dr. Murphrey. We really appreciate